Hey, future doctors. Thanks for tuning in to Spoonful of Sugar, a podcast made for medical students by medical students to help the medicine go down. My name is Jess Wang. I'm a student at University of Illinois, Chicago, and I will be your host today. Today, we're going to be talking about bones, something we rely on them for literally everything. Yeah, we are one of the most underestimated organ systems on shelf exams. Today, we're diving into bone metabolism disorders, osteoporosis, osteomalacia, and Paget disease. These three conditions get confused easily, but once you nail down the underlying physiology, telling them apart becomes surprisingly intuitive. Throughout this episode, I'm going to be throwing questions your way. Feel free to pause, think it through, and come back. This is a review, so don't stress if something doesn't click right away. Let's get into it. First, we're going to be talking about the bone remodeling basics. Before we talk about what goes wrong, what are the two main cell types responsible for bone remodeling, and what does each one do?
Right, the answer is osteoblast, which builds bone.
Lay down osteoid and collagen matrix. And another one is osteoclast, which break down bone and responsible for resorption. The balance between those two will determine the density of our bone. Next, what hormone is the master regulator of calcium homeostasis, and where is it produced? Right, if your answer is PTH, which stands for parathyroid hormone secreted by parathyroid glands, you're correct. And then it works by raises serum calcium by increased osteoclast activity, increase renal calcium reabsorption, and increase the active form of vitamin D production, which is also called calcitriol. Its counterpart, calcitonin, and I remember it as to tone down calcium, is secreted by the parafollicular cells in the thyroid gland that inhibits osteoclast activity and renal reabsorption of calcium and phosphate to reduce serum calcium, which is also the pathological cell in the medullary thyroid cancer. Next, what does vitamin D actually do at the gut level? Right, so it increases intestinal absorption of calcium and phosphate. And vitamin D must be activated in the liver to 2,5-hydroxy vitamin D, and then to the kidney to 1,2,5-hydroxy vitamin D, which is the active form of vitamin D, also called calcitriol. There are so much more to discuss regarding the calcium homeostasis, but we won't cover them here today, so make sure to review them before exam if you're unfamiliar with it. So next, we're going to talk about the pathological bone disease. The first one is osteoporosis. So what is osteoporosis in one sentence? Right, it decreases bone mass, but the bone that remains, it is structurally normal. It just has less bone, but the quality remains the same. So what are some common fracture sites in osteoporosis? If your answer is first vertebral compression fractures, you're absolutely correct. It is the most common overall fracture type in osteoporosis patient. And the next one is femoral neck fracture, which is a big morbidity in elderly. The next one is distal radius, also called the Colles fracture, commonly caused by the Fuchs injury, which stands for fall out on outstretched hands. So what would you expect labs to show in osteoporosis? Right, so the calcium will be normal, phosphate will be normal, PTH will be normal, the ALP will also be normal. And if it happens after fracture, it could be mildly elevated. So the key important here is that osteoporosis is a silent lab picture. Everything is normal. There's just less bone being made. So how do we diagnose this? That's correct. We do something called the DEXA scan, which stands for Dual Energy X-ray Absorptiometry. And then we'll obtain a score called T-score and represent as standard deviation from the targeted population. And if you have a T-score of below or equals to minus 2.5 standard deviation, it's considered as osteoporosis. And if it's minus 1 to minus 2.5 standard deviation, it's considered as osteopenia. So what are some major risk factors for osteoporosis? Right. So it's postmenopausal women due to loss of estrogen and then increased osteoclast activity. It can also be caused by long-term corticosteroid use, which is most common secondary cause that inhibits osteoblasts. Some other major risk factors also include advanced age, low BMI, smoking, alcohol, and a family history of fracture. So when do we screen for osteoporosis, and who do we screen? So according to the USPSTF recommendations, women aged 65 and older will screen all of them with DEXA scan. And for women under 65 who are postmenopausal, you will also screen them if they have risk factors such as low body weight, smoker, family history, or prior fracture. So what is the first-line treatment if you have been diagnosed with osteoporosis? Right, it's bisphosphonates, such as alendronate, risedronate, which works to inhibit osteoclasts. And some of the very common side effects that staff love to test about is the osteonecrosis of the jaw and esophagitis. Other treatment includes calcium and vitamin D supplementation, rank L inhibitors, which is also called denosumab for high-risk patients. And another non-pharmacological treatment is the weight-bearing exercise. Next, let's look at osteomalacia. So how is osteomalacia different from osteoporosis? Right, osteomalacia is normal amount of bone, but poor mineralization. The osteoid is laid down, but not properly calcified. Think of it, plenty of framework, but there's no cement that's being poured in. So what causes osteomalacia? If your answer is vitamin D deficiency, you're correct. That is the most common cause of osteomalacia, which can cause by decreased intestinal calcium absorption, which leads to decreased mineralization. Some other causes are chronic renal failures because they can't activate vitamin D, malabsorption such as Crohn's or celiac disease, and anticonvulsant use. Drugs such as phenytoin, which is a liver CYP450 inducer, which will increase the metabolism of calcitriol, which decrease the available active vitamin D inside the body. So what is the pediatric equivalent of osteomalacia called, and what are some classic findings? If your answer is rickets, you're correct. Some of the classic findings include the bow legs, also called genu varum, the ricket rosary, which is a costochondral junction beating, the frontal bulging, and also something called the Harrison groove. So what do the labs look like in osteomalacia? Right, so the calcium will be low or low normal, the phosphate will be low, and then PTH will be increased due to lack of negative feedback because they're trying to compensate and increase the calcium inside the body. And the ALP will also be increased because the osteoblasts are working overtime, and then 2,5-hydroxy vitamin D will be decreased. So the PTH here goes up is due to a normal response to low calcium. It's a secondary hyperparathyroidism, not a primary. What are some classic X-ray findings in osteomalacia? Right, so there's something called the loser zones, also called the pseudo-fractures, are the radiolucent lines perpendicular to the cortex. This would be very useful if you pull up a X-ray picture of osteomalacia, and it would be a lot easier to understand. The treatment for this is vitamin D and calcium supplementation. If it's a secondary cause due to things like chronic renal failure, then you treat the underlying cause. The last section of this podcast is the Paget disease of the bone. So what is Paget disease at its core? Right, it's disordered, accelerated bone remodeling that occurs in two distinct phases. And understanding those phases explains everything about the disease. The first phase is called the lytic or osteoclastic phase, where osteoclasts go into overdrive, aggressively resorbing bone. This is the hot destructive phase. The bone becomes hypervascular and weak. The second phase is a sclerotic or osteoblastic phase. the osteoblasts will try to compensate by laying down new bone, but they do it chaotically, producing disorganized woven bone instead of normal laminar bone. The result is that the bone is big and dense on X-ray, but structurally fragile. The bone is very large but weak in Paget's disease. It's like a building that looks solid from outside, but it has no structural integrity inside. Many patients exist in a mixed phase where both processes are happening simultaneously. So what are some classic demographics for Paget disease? Right. So it's a rare disease relatively, about 1 to 3% population in Western countries, and mainly are male and mainly are older adults above 50 years old. It is also common in countries such as England, Australia, and New Zealand. Do you know where is most commonly affected by the Paget disease of bone? Right, so the skull, the pelvis, the femur, the tibia, and the lumbar spines are some common sites affected by Paget's disease of bone. What are some clinical features? If you say it's often symptomatic, that is correct. Sometimes it is found incidentally on X-ray or a dramatically independent increased ALP. If the patients exhibit symptoms, some of the features are bone pain, deformity, such as bowing of the tibia, also known as the saber shin, the skull enlargement, often commonly shown up in question as having a hat that no longer fits. Another very common symptoms that the test takers like to ask about is a hearing loss, which is caused by cranial nerve 8 compression from skull thickening. They can also have increased skin warmth over affected bone due to hypervascularity. And another very important symptom is the high output heart failure, because when the bone becomes highly vascular, it acts like an AV fistula and causes high output heart failure. So what would the labs show in Paget's disease of bone? Right, so the ALP here will be the key indicators, and it will be markedly elevated, reflects the osteoblast hyperactivity. The calcium will be normal. Unless the patient is immobilized, then there could be hypercalcemia. The phosphate will be normal. And another key indication is the urine hydroxyproline, which would be increased because it's the marker for bone matrix breakdown. So the key important lab here is that ALP will be upped, and the calcium and phosphate will likely be normal, because the regulation of calcium and phosphate by the kidney and the GI systems are normal. And this is key distinguishing labs from osteomalacia and osteoporosis. There is one key complication of Paget's disease that's commonly tested, which is very rare but high yield. Do you know what it is? Right, it is osteosarcoma, and it is suspected if there's sudden worsening of bone pain or elevated ALP after a period of stability. The treatment of Paget's disease, the first line is bisphosphonates, just like osteoporosis. And then if the patient is refractory to bisphosphonates, sometimes calcitonin can also be used. And here, just to point out, this Paget's disease of bone is different from another two Paget's disease that you may learn in female reproductive system, which is the Paget's disease of the breast and Paget's disease of the vagina. Now let's do a quick recap of the lab comparison between those three diseases. For osteoporosis, you have normal calcium, normal phosphate, and normal ALP. So everything will be normal. We're just laying down less bone. For osteomalacia, you will have low calcium, low phosphate, and high ALP and high PTH. For Paget's disease of bone, you will have normal calcium, normal phosphate, and very high ALP, and only ALP will be elevated. All three diseases can present with pathological fracture, but their pathophysiology, demographic, and differential labs can help you differentiate between them. And now let's recap. We've covered three bone disorders that love to show up on shelf exams. First, osteoporosis is about decreased bone mass with normal mineralizations. Labs are all normal, diagnose with DEXA scan, and treat with bisphosphonates. Osteomalacia is about poor mineralizations due to vitamin D deficiency, most commonly. You get low calcium, low phosphate, high PTH, and high ALP. In kids, this is called the rickets. The Paget disease of bone is disordered remodeling, producing chaotic but dense bone. The key labs here are dramatically elevated ALP with normal calcium, and watch for osteosarcoma as a key complications. The lab patterns here are going to be your best friend distinguishing those three. Commit those to memory, and you'll be ready for whatever the question throws at you. And now, let's go through a couple practice questions to apply what you have just learned. Question 1. A 68-year-old woman presents after a minor fall resulting in a wrist fracture. The DEXA scan shows a T-score of minus 2.8 standard deviation. Her serum calcium, phosphate, and ALP are all within normal limits. What is the most likely diagnosis? A. Osteomalacia, B. Paget's disease, C. Osteoporosis, and D. Primary hyperparathyroidism. Right, the answer is osteoporosis, because the DEXA scan is below minus 2.5 and all the lab values are within normal limits. Question number 2, true or false? In osteomalacia, PTH levels are typically low because the problem is intrinsic to bone remodeling rather than calcium sensing. Right, the answer is false. The PTH should be elevated as a compensatory response to low serum calcium caused by poor intestinal calcium absorption from vitamin D deficiency, also known as secondary hyperparathyroidism. Question number 3. A 72-year-old man is found to have an ALP of 450 unit per liter, which is markedly elevated. His calcium and phosphate are normal. X-ray shows an enlarged, thickened skull and a bowing of the left tibia. What is the most feared long-term complication of this condition? A. Pathological hip fracture, B. Osteosarcoma, C. Hypercalcemic crisis, D. Renal osteodystrophy. Right, the correct answer is osteosarcoma, which is a rare but deadly complication associated with Paget's disease of bone. And thank you for listening. If you found this episode helpful, please subscribe to our podcast. If you have any questions, comments, or concerns, visit our website at spoonfulofsugar.org and then post them under the link for this episode. Good luck with studying, and remember that if you ever have an SOS moment while studying, Spoonful of Sugar is always here to help the medicine go down.